Good morning and good afternoon. Thank you for joining us and welcome to this fourth webinar in a series on how to use the MediSense Nociception Index Monitor to help guide your dosing of analgesics. I am Frank Overdyk, an anesthesiologist and the consultant medical director for MediSense, and I'm based here in beautiful Charleston, South Carolina. We started our first webinar, this is the fourth, so discussing why we would need a nociception monitor. What value specifically can a nociception monitor add that we don't already have with all our other monitors? How do you use the monitor to improve outcomes? And more specifically, which type of patient and which type of surgery benefits the most? In the second webinar, we had two experts in the care of obese and morbidly obese patients who shared how the NOL monitor helped them minimize or optimize opioids in this population who had high risk of serious adverse events from opioids. The third webinar had two clinicians who described the value of NOL indexing when doing regional anesthesia nerve blocks, which are an essential component of multimodal analgesia. So we have different applications, and you can go back to the website and you can look at these previous webinars as well as other ones and get an idea of the flow and all the different places you'll practice. This is going to be useful. In this fourth series, we have Pascal Lafferriere, an academic Canadian anesthesiologist, who will describe his journey with nociception monitoring from starting as a healthy skeptic, like, why do we need this box, to where he is today, which is a strong advocate for this technology and one of the most experienced clinicians with NOL in the world. Dr. Lafferriere is an assistant professor of anesthesia and pain medicine at the University of Montreal, as well as an adjunct professor of anesthesia at McGill University. He shares his time between clinical work and research, and his research is supported by the Quebec Research Fund in Health, which focuses on innovative technologies and artificial intelligence. He's uniquely qualified for this because besides his medical anesthesia training, he has a master's in industrial engineering and mathematics, and he completed a fellowship in bioinformatics at UCLA. So this is the guy who will tell you about the application of AI to nociception monitoring. Dr. Lafferriere currently presides over the Laboratory of Innovations in Anesthesia in Montreal. Pascal, welcome.
Thank you very much. It's a pleasure to be here.
Any questions that come up from the audience during these? I'm having a short introduction, and then Dr. Lafferriere will be giving his talk. Please put them in the Q&A, and we will save them and address them at the end, time permitting. We will either discuss them in this hour or we will get back to you. I'm going to start and spend the first 10 minutes introducing this monitor to those of you who are new to the concept of nociception monitoring, and specifically this device. So if you were on previous webinars, you may skip this part, you may get a cup of coffee, come back in 5 or 10 minutes, and then the really interesting person who's going to be talking. So, as anesthesiologists, I'll just make that a little smaller. As anesthesiologists, we are responsible to provide these three components of an anesthetic. Since the 1970s, we've had an objective monitor for muscle relaxation, the Trainer 4 monitor, which has been vastly improved now to give us the quantitative monitoring of neuromuscular blockade. In the 90s, we got our first depth of anesthesia monitor, hypnosis, the BIS. We now have several technologies intended to measure depth of anesthesia monitors as SedLine, Narcotrend, bispectral index, etc. But we've never had an objective monitor for guiding and our dosing of analgesics specifically. We rely on surrogate vital signs, heart rate and blood pressure being the most common ones, but these are not necessarily indicative of pain or nociception in patients, and they may be false positives, certainly in situations where a patient has essential hypertension or beta blockers. So pain is a subjective sensation, which can only be quantified by asking the patient, talking to the patient. But under anesthesia, the patient's unconscious. They can't tell us their pain level. Thus, we use the term nociception and we have to do something else. So how we do this is by measuring nociception or stimuli during surgery, which are usually manifest by the activation of the sympathetic nervous system, which you see here. Blood pressure increases, our heart rate increases, our pupils dilate, our skin starts to sweat. And currently, again, we use mostly blood pressure and heart rate. There are other types of devices that use different technologies, but the NOL uses blood pressure increases, heart rate variabilities, and skin vasoconstriction, which all happen with the activation of the sympathetic nervous system. Here you see the probe. It sits in a cradle. And it measures the sympathetic tone using the photoplethysmograph is obviously one of the transducers. You're all very familiar with the PPG because it's the same signal from which we derive oxygen saturation. This probe does not measure oxygen saturation. It uses a single light frequency to measure the pleth amplitude. As I just mentioned, sympathetic activation causes vasoconstriction in the peripheral bed as well. And so pleth amplitude and its derivatives are an important measure of nociception. The same for heart rate and heart rate variability. We use heart rate variability in a lot of monitors. A lot of the commercial consumer monitors use heart rate variability. If you have an iWatch, you will see that that's how they do a lot of the tracking your sleep, tracking your heart rate and heart rate variability. And then we have skin conductance, sweat. So that changes as well. As I mentioned, increased parasympathetic output causes lower skin impedance as a result of sweating. So there's a machine learning algorithm that takes all these signals and generates the NOL index. Now, the monitor also, this, as you see here, has skin temperature and it has a movement accelerometer. What doesn't these days? But those are just used as guardrails. Those are not used in the monitoring, in the derivation of the number that we get. I'm going to give you a high-level, brief description of how the monitor uses these signals to derive a continuous measure of unopposed or residual stimulation during anesthesia. I use the term unopposed or residual because the NOL index measures the degree of stimulation minus the degree of analgesia provided by the onboard opioids, right? So you have a very strong stimulus, but you've given 5 cc's of fentanyl. That some product of those two is what that NOL index tells you. So it's a combination of those two. We call this really the nociception, anti-nociception balance. But in simple terms, it's however painful the stimulus is, minus whatever you gave to treat it. The nociception monitor uses a machine language. It's called random forest. With this technique, the model is taught what pain looks like in terms of these physiologic signals from the sympathetic nervous system. The training for this model is done from a set of these physiologic signals derived during 200 or more general anesthetics. During those 200 or more cases, researchers marked the precise time of 4 events during these 200 cases: intubation, surgical prep, trocar insertion, and surgical incision. And these 4 events have different levels of stimulation, as we know. Intubation is a type of severe stimulation. Surgical prep is almost no stimulation. And then we have mild and moderate for skin closure and trocar. And so what they did during these 200 cases, they annotated when these events happened, and they collected those data sets. Here, by way of example, we have 4 of them: heart rate variability, pleth amplitude, skin conductance. But there's many more. There's derivatives of these as well that it uses. But this is just for an example. These, as we say, have mild, moderate, or severe degrees of pain. We all agree that's sort of the level of stimulation. So then by assigning or labeling these stimulating events to the NOL signals, the model learns what pain looks like in that patient. It's personalized to that patient. And that's why we call this a supervised or labeled random forest algorithm. Now, now that we have the model trained, let's go through how the null is determined in real time for a specific patient by going down the decision trees. Your patient spikes to 130. Okay, so we go in the decision tree over here. 130 is to the left is greater than 95. So we're on this decision tree, and it's also greater than 120. So the heart rate candidate is going to vote for this stimulus being severe pain. Now we're going to look at the pleth amplitude candidate here, and let's say the pleth amplitude at that time is 0.4. So again, in the first decision tree, it's going to go left. It's going to stay here, but it's not less than 0.3. So pleth amplitude is going to vote for this being. This whole, you notice they look like little Christmas trees, very appropriate for this time of year. And when they all get together, they all make their decisions, and very democratically, they all vote on what is the most likely degree severity of the stimulus for this at this particular time. And that's how it derives its null value. So we've explained this in terms of 4 discrete degrees of stimulation: none, mild, moderate, and severe. But in reality, the null scale is a continuous scale. It goes from 0, no nociception, to 100, extreme nociception. It's not a linear scale, which means a null of 50 is not twice the stimulation as a null of 25. The index is simply an ordinal scale, which means the higher the number, the greater the stimulus is. And that's how, as with many continuous monitors, looking at the patterns and the trends of null is really important. Now, of importance is a receiver operator analysis, a ROC analysis, was done on the data to optimize the sensitivity and specificity for distinguishing painful or noxious stimuli from non-noxious stimuli. And that threshold turned out to be 25. So the indication from the monitor is that if your null index is greater than 25 and sustained for more than a minute, you should consider adding extra analgesics. If it's not, you're likely to have a nice nociception, anti-nociception balance. So how well does the null index reflect different levels of stimulation compared to surrogate measures for pain that we always use, heart rate and blood pressure? So Martini took 3 discrete levels of stimulation, non-noxious, incision, and intubation, and measured how well the heart rate, the blood pressure could distinguish these stimuli. They added bispectral index as a control because in anesthetized patients, as you can see here, these patients are all with a BIS between 40 and 60. The hypnosis tells us nothing about nociception, as you can see here. It couldn't distinguish these 3. Heart rate did a little better. Heart rate could not distinguish a non-noxious event from an incision, but it could intubate. It could distinguish the intubation. Mean arterial blood pressure a little better. You can see the slope is steeper. So this could be a quantitative relationship here, but it was not statistically sufficient. But the nociception level, the null index, clearly differentiates these 3 types of stimulation, suggesting that the null does a pretty good job of telling us the severity of stimulation. Now, I hear what some of you are saying. So only null correctly ordered the level of nociception intensity. Some of you are going to say, that's very nice, but you know, my patient in front of me is not one of those 200 you train the model at. So how good is this model in dealing with interpatient variability? Because we have, you know, the demographics and the surgeries and everything is different. Let me just move Pascal over to the bottom here. So what Kurt Reutzler did at the Cleveland Clinic, he said, okay, let's pool all these null studies together. We'll throw all the null values in a bucket. We'll throw all the demographic and the qualifiers and the case types together, and then we'll see how they pan out. How did null compare in distinguishing a non-noxious stimuli from a noxious stimuli in this bigger data set? Here, the threshold of 25. So now 25 is this green dotted line. That's the binary differentiator between non-noxious and noxious stimulation. As you can see, it held up quite well in all these groups. By sex, males and females were distinguished between non-noxious and the boxes, which are the first and third quartiles. This is a box and whiskers forest plot, are pretty well distinguished. It did the same for age. It could tell under 65 and over 65. They responded similarly to noxious stimulus, and almost nothing for non-noxious stimuli. Size, BMI, same thing. Type of hypnotic, desforing, Sevo, or Tiva, propofol. Again, the threshold of 25 does a pretty good job at distinguishing these. ASA status, ditto. And lastly, type of opioid, Remy versus fentanyl, it did the same thing. So generalizability for the algorithm in its current form with a threshold of 25 is quite good. All right, hopefully that's a little bit of background for everybody. And now we get to the main event. Dr. Pascal Lafferriere-Langlois, please take the stage.
Thank you very much. I'll start by sharing my screen. I'll replace screen share.
Yeah, I'll stop sharing. There we go.
And everything should be working now, is it?
It looks good.
Okay,
I don't
fantastic.
see, hold on, I don't see your presentation yet. I stopped sharing, I think.
I see you are screen sharing. I can start over if needed.
I am not screen sharing according to my Zoom screen.
I mean, I think I am, but I can stop.
Okay.
I'll start over to make sure that it's properly set it up. There you go.
Yes. Perfect.
Okay. Okay. Perfect. Well, it's a true pleasure to be here, and thank you for the introduction, Dr. Overdyk. So as a recall, I was specifically asked to share my own personal experience with the NOL index. And I think it's relevant to mention that during my residency, during my training, I didn't use any form of nociception monitors. I was using, of course, heart rate. I was using blood pressure. I was using these indirect sign of sympathetic nervous system activity to guide my administration of opioids, for example. But it really is when I moved to Montreal after my fellowship that I started using nociception monitoring and technologies. So part of my presentation will actually be to walk you through my thought process when I started using this kind of technology, to assess that it was relevant for my clinical practice. And once this is done, I will discuss a few clinical cases that I think are relevant and in which NOL index helped me improve my personalization of critical care. So these are my disclosures. And as mentioned, the objectives really are to walk you through this first assessment of the technology, the way that I approached it, and then explore these case studies. But before jumping onto the real material, I want to lay out what was the result of a survey that was conducted in 2022, and in which the authors asked the respondents what were their current use case for both depth of anesthesia monitoring and nociception monitors. And not surprisingly, we observed that hypnotic monitoring was used more frequently than anti-nociception monitoring. And more than 30% of the respondents, which were mostly from Europe, mentioned that they didn't use any form of nociception monitoring. And I'm from Canada, and I sincerely believe that if we had more respondents in this survey from America, we would see a rightward shift of this group. I think it's something that is more prevalent in Europe than here in America. And interestingly, 58% of the respondents also reported that they had a lack of knowledge of the published algorithms that were out there, and hence explained at least partly why they didn't use the technology. But also, what was very interesting in these results is that a lot of postoperative outcomes were considered to be improved when using this kind of technology. So, of course, this was the opinion of the respondents. They mentioned, for example, the anti-nociception monitoring was better than depth of anesthesia to improve or reduce the event of postoperative myocardial infarction. And even if DOA monitoring was highly relevant for postoperative delirium and postoperative cognitive disorders, we also see that around 50% of the respondents considered that anti-nociception monitoring was relevant to prevent this kind of adverse events. So it's very interesting afterwards to see that it's not used as much as it is, even if the population still think that it's highly relevant. And to be honest, again, during my residency, during my training, I was completely on the right side of that survey. I never used it. And when I landed in Montreal, when I started using NOL index, this was my actual thought process. So before starting to use any technologies, before starting to use any tool, there are some baseline questions that you must ask yourself. And these are the 3 questions, in my opinion, that we should be asking every single time that we start using new technologies. So in the specific context of nociception, the first question to ask is, do we actually want to monitor nociception? Do we need to monitor it? The second one is, are we able to monitor it? So if it's relevant, do we have the technologies right now to monitor what we want to monitor? And lastly, the third question is, if it's relevant to monitor it and we're able to do it, are we able to capture some clinical benefits of using it? So these 3 questions will guide the first section of the webinar before talking about clinical cases. So first question, do we want to monitor nociception? Do we need to monitor nociception? And my approach to this question is that as soon as you have to walk a fine line, there is relevance in using a monitor that provides you data on this outcome. And by fine line, I mean that there are potential harms in under-delivering what we have to deliver or over-delivering it. So in the specific case of opioids medication, of course, we know that if we give excessive analgesia, if we give excessive opioid medication, we will increase the rate of postoperative nausea and vomiting. We know that it can lead to respiratory depression. But on the other hand, if we give too little of opioids, we will have a patient that might wake up with some pain, who might have an excessive activation of the sympathetic nervous system, heart ischemia, hypertension, tachycardia, name it. So these are all complications that you know, and the fine line thus exists because we don't want to go on either side. Whether we give too much, too little, we'll have that delayed post-op recovery and we'll have that reduced patient satisfaction. So the first question is pretty straightforward. There is a fine line, so it's relevant to be able to monitor nociception. So the following question that I asked myself is, are we able to monitor it? So are the tools available really monitoring what we call nociception? And this is the same slide that Dr. Overdyk presented slightly back. I think it's pretty clear that we have some tools to monitor hypnosis. We have some tools to measure muscle relaxation. So what about analgesia? And to go in more depth regarding that, I want to come back a little bit to the biology of that nociception stimulus. So we've all seen this kind of graph. Basically, when we have a stimulus, nociception stimulus, it will walk up to the central nervous system, to the brain, while where it will be relayed from the thalamus to a different region of the brain. So of course, during general anesthesia, it's hard to assess what is happening in the frontal cortex and the somatosensory cortex regarding pain activation. If the patient was awake, of course, he could tell us that he's feeling some pain. But in the context of general anesthesia, we have to rely on the remaining path. And that remaining path, of course, is the limbic system, which will relay the information to the autonomous nervous system and will activate that sympathetic activity. So prior to the era of quantitative nociception monitoring, of course, we are using heart rate, we're using arterial pressure, we're using other indirect signs of this activation, as it was discussed previously. However, they're hard to quantitatively monitor. And most importantly, they have a poor sensitivity and specificity to the actual event that we are trying to monitor in this context, which is nociception. And the reason why they have this poor sensitivity and specificity is because they can also be altered by alternate event in the intraoperative period. So not only the nociception activity can affect these parameters, especially the one that we are able to quantify, such as heart rate. And it's not a question that we recently started asking ourselves. This was a systematic review that was published in 2013. And the reason why I'm bringing this paper up is only to demonstrate that at that moment, we can appreciate in the first and second column that there were already some methods out there that were attempting to measure nociception and guide the precision medicine that we want to deliver. And if we look at the current state of the commercial products that are widely available, there are different ones that we can appreciate on this slide. Here at Maisonneuve Hospital in Montreal, where I'm working, we have the nociception level index, the PND 200 monitor in almost each of our operating rooms. So of course, this is the one with which I have the most experience. And the reason why it is the one that we use is for A, its simplicity regarding the installation of the probe, but B, that notion of being a multi-parameter parametric index. So as it was briefly mentioned in my background, I'm a data scientist guy. I did some bioinformatics. I like to do research surrounding artificial intelligence. And if there is one thing that we know very clearly in these days is that the more input of data that we have, the more the quality of the output data will be. So if we're able to aggregate multiple sensors, if we're able to aggregate multi parameters and create this specific output, if we have more information at the beginning, the relevance of the output will be increased. So if I come back to this specific question that I wanted to answer, are we able to monitor nociception? And I will break down this specific question in, let's say, 2A and 2B. So are nociception monitors more sensitive and specific than vital signs to capture nociception stimulus? So if a NOL index is, or nociception monitor is able to capture these nociception stimulus, for example, standardized nociception stimulus, we know that it's in the good way. And the second question that we should ask ourselves is, if I start giving some anti-nociception medication, for example, if I give opioids medication, is the monitor able to capture the fact that I just administered this medication? And if it's able to capture both the standardized stimulus that we know is happening and capture the fact that we just administered some anti-nociception medication, well, I consider that yes, it is able to monitor the nociception. So this was my thought process when I was looking at it. This paper was published in 2019 in the Canadian Journal of Anesthesia. It was published by the group here at Maisonneuve-Rosemont immediately prior to me joining the team. So in this protocol, the objectives was to assess what is the signal that is captured by the NOL index when standardized stimulus, nociception stimulus, are given at different rates of remifentanil infusion. So in the protocol, there was a standardized induction drug. There was the intubation that was made. There was the epidural installation, if relevant, in the specific case of the surgery that we were doing. But most importantly, during the surgery, the remifentanil dose was set at a specific value. The surgical stimulus was stopped for a few minutes, for 5 minutes, and then a standardized tetanic stimulus was made with a neurostimulator, a pain stimulus or nociception stimulus. And this process was made at different remifentanil infusion rate, as I mentioned. This is when the procedure was made, and the different levels of remifentanil were 0.005, so a very mild dose, at 0.05 and 0.1 microgram per kilo per minute. And this graph is similar to the one that was presented by Dr. Overdyk slightly before. What we appreciate is that the BIS index didn't capture these nociception stimulus independently of the dose of remifentanil. The NOL index did, and we see that there were some modification also on the heart rate and the mean arterial pressure. But when we created the ROC curves to establish what is the specific sensitivity and specificity of these different monitors to capture that nociception stimulus, we can clearly appreciate that the NOL index provided a superior capture of these standardized nociception stimulus. The NOL index reached an ROC, so area under the ROC curve of 0.92, which is relatively good in the context, while heart rate and mean arterial blood pressure was around 0.7. And as a recall, in the ROC analysis, 0.5 means that it is totally random. So the baseline is a value of 0.5 of ROC, and we had 0.7 with heart rate and mean arterial pressure, and we reached 0.92 out of a maximum of 1 with the NOL index. And this is not the only paper that explored these results. There were other papers that had been done previously to the one that was published by this center. Of course, I preferred to present the one that had been done here. And the results were consistent. NOL provided a better sensitivity and specificity to capture the standardized nociception stimulus, and that was the case in different studies and different countries. So this first question, are we able to capture standardized stimulus? The answer was yes, based on these scientific publications. And the next question was, if we administer some opioid drugs, are we able to capture this response? Is the NOL value going to go down, for example? So this is a paper that we published also. In this paper, it was a secondary analysis of a group of patients that had been analyzed in a completely different settings. But basically, we used the data. We worked with Polytechnique Montreal here, and we extracted further information. And in this graph, what you appreciate is the fact that we have the NOL index here, we have the mean arterial pressure, and we have the heart rate. Each vital signs or each feature is presented both before the administration of the opioid and after the administration of the opioid. So in other terms, all the results from this specific parameters were plotted here, and they were plotted from the lowest value to the highest value. And that was done prior to the administration and after the administration. So we see that for the heart rate and for the arterial pressure, the two curves almost perfectly align, meaning that no specific capture of the administration of the drug was made using these vital signs. But when we look at the NOL index, interestingly, as soon as you reach more or less a value of 15, we notice that there is a difference that appears. So in other words, the pre-administration value was higher than the post-administration value of for the NOL index, and that was true as soon as the value at which the drug had been administered was higher than more or less 15 in the NOL index. So if the value of NOL was below 15 and something was administered, of course, no signal appeared because probably this was not an administration of opioid that should have been made. So in this population, we had a group that was blinded to the NOL index, and this is why we see that this kind of event happened if the clinician was blinded. So if I go back to this slide, are we able to monitor intraoperative nociception based on the fact that we capture standardized nociception stimulus and based on the fact that we capture the administration of the anti-nociception medication? I became confident that yes, we are able to monitor intraoperative nociception. So the third question becomes, are there clinical benefits? And my goal in this presentation was not to go over a thorough literature review of these results, but of course I will present you a few papers. If you have other questions, it will be a pleasure to talk about it, but other presentations have been made specifically on this subject. So the two papers that I will be presenting are the ones that were published by Mayer in 2019 and 2020. So in this paper, a group was exposed to NOL index and a group was not. And what they noticed is that even if there were no changes in the pain levels of the patient when they reached the post-anesthesia care unit, the patient received 30% less intraoperative opioid during the procedure. So in other words, even if they received less medication, less opioid during the surgery, they reached the PACU with a similar pain level. So in other words, it seemed to be more tailored to the actual patient need and administered at the right moment. But interestingly, also what the authors noticed is that the patient experienced less hypotensive events and required less vasopressors during the surgery. So it's an association. Of course, we can't conclude, but it's interesting to see that this association exists. The second paper, published a year later in 2020, in this case, it was fentanyl that was given. The intraoperative dose of fentanyl was similar between the two groups, but the pain level when the patient reached the PACU was reduced in the NOL index. And interestingly, they also looked at the stress hormones and measured them. So I presented these two papers really to outline what are the usual outcomes that we can monitor when we explore some nociception monitors. We can either appreciate that without any increased pain in the PACU, there is a reduced administration of opioids during the operating room, or with the same level of intraoperative medication that was given, we appreciate a reduction of the pain level of the patient when he reaches the PACU. And this is as close as it can get to the ground truth that would be the patient telling you that he is experiencing pain if he was awake. So we have to rely on these surrogate outcome. We have to rely on these outcome to really explore what would be the theoretical ground truth if the patient was awake. And of course, there has been multiple systematic review and meta-analysis afterwards. This one is systematic review published in Anesthesia in 2023, and the clinical results were indeed positive in a lot of these forest plants. So that third question, are there clinical benefits? Yes, I believe that there are clinical benefits too, and this is why throughout my journey, I started using the NOL index in a lot of my clinical scenarios. So this finishes the first section of the webinar, and for the following part, I will be showing mostly how we use it here at Maisonneuve. Take a small sip of water to let you think about some questions regarding this first part of the webinar. Okay, so how do we use the NOL index here at Maisonneuve-Rosemont Hospital? As I said, it's a monitor that we have in nearly all our operating rooms. Initially, we started using it a lot in the context of research. So it was a great tool to standardize the medication administration across different groups. And this is a protocol of medication administration that we often use in our research protocols. So basically, you see that there are 9 different scenarios. These 9 different scenarios reflect varying vital signs and NOL index value, and will guide the clinician on which drug should be administered in the objective of standardizing these drug administration. So for example, of course, if MAP is relatively low, some vasopressors will be administered. If the NOL index becomes higher than 25, opiates will be recommended. And if there is high blood pressure with a NOL index that is below 25, some antihypertensive drugs will be administered. I think it's always relevant to have an idea of what kind of protocol is used, but we have to keep in mind that we are clinicians. So the goal is not to blindly follow some rules, and if the NOL index shows a value above 25, you administer medication. If not, you do not. We have to input different data signals. The NOL index is one of them, and this is how we should approach our decision-making in the intraoperative setting. From my personal experience outside of the research context, where I think that the NOL index is the most interesting for my clinical practice, is to improve the level of personalized care that I provide to my patients. I think that with it, we are able to capture some granular events in which we can personalize, or we can tailor our opioid administration. I personally like to use remifentanil infusion because its very short half-life, meaning that we can really capture this noise of nociception and tailor our administration based on this granular level of activity. The other thing that I use it for is to guide my administration of analgesic. So, of course, this is linked to the personalized medicine concept. It's very useful, as it was discussed in previous webinar, when combined with regional anesthesia, especially when you combine the original anesthesia with general anesthesia. Very interesting use case is also when you want to relay from opiates to antihypertensive drugs. I will have a case study based on this scenario. So the first case study that I want to present is really to demonstrate this increased sensitivity and specificity of the NOL index compared to the other vital signs that I used to rely on when I was a resident. So I have a time span going from 10:49 to 11 a.m. in a case that I was doing a few weeks back. And here, what we will appreciate on the left, on the picture of the left, is the previous state, and on the right is the new state in which we are going. So in this first scenario at 10:49, we can appreciate that, well, the NOL index is relatively low at 3. There is some wiggling, which means that we are not in an excessive level of remifentanil administration. We appreciate that the heart rate is around 70. There's a mild hypertension with 145 of systolic. We have 145/84. If we go 1 minute later, what we appreciate is that the NOL index start capturing some nociceptive stimulus, or some sympathetic nervous system activity. We also know that the heart rate and the blood pressure didn't move at all at that moment. If we go 1 minute later afterwards, we see that the NOL index at that moment, I administer medication actually. So we appreciate that on the 46 of NOL index, I decided to administer because we can appreciate that that signal was present for more than 1 minute. And despite that, there were at that moment absolutely no movement on the heart rate. And we see that after the administration of the opioids, when the NOL index started to come back to its baseline level, the heart rate, the blood pressure slightly increased also. If we keep moving forward, the heart rate still didn't move. Blood pressure remains at that slightly elevated level. We have a NOL index that lies within that well-balanced nociception to anti-nociception status. And if we keep moving forward again, we see that the NOL index is well stabilized. Heart rate still never moved. Hypertension remains exactly the same. And that is the case also 5 minutes later when we are in good state. So in this specific example, what I really want to put forward is exactly that slide from which I spoke earlier. When we use the NOL index, from my experience, we are able to react more promptly because of the increased sensitivity and specificity of the monitor. I feel that I am able to administer the bolus of remifentanil at the right moment to really target it. And sometimes I will not even appreciate a single motion of the heart rate or the blood pressure because it was stabilized right beforehand. A second case study that I want to put forward is regarding the analgesic dosing. So I will present you 2 cases. The 2 cases, both are cholecystectomies. During these cases, NOL index was used, where we're at this exact same moment of the cholecystectomy, during which there is some pulling of the gallbladder, there is some burning to try to dissect the gallbladder. And we all know that there are some events during in the perioperative settings that there is a significant stimulus. So for example, we know that intubation is a very high stimulus level. So we used to give preemptively medication to try to blunt the sympathetic nervous system prior to the stimulus happening. And there are some painful events during surgeries. But there are also some events that patients will react differently on. So for example, in this specific situation where there's the exact pulling and burning that we see with cholecystectomy, we appreciate that in this first patient, we had a NOL index that slightly moved, that went over that threshold of 25, but no medication was administered because the cynetic was wiggling and seemed to want to go down relatively quickly. And in fact, this increase didn't last 1 minute, so opiate medication was withheld in this specific context. But on the other side, we had the exact same scenario, but with this pulling and burning, the stimulus remains above that 25 threshold that we mentioned earlier. It had that kinetic also of something wanting to go up, and in that case, analgesic drug was administered. So it's interesting to see that the same kind of surgical movement will, of course, generate different nociception response in the patient, and we are able to capture that and to give our medication. And most interestingly, it becomes relevant when the patient has a specific resistance to the medication that we are giving. So in this third study, we can have a similar patient, but who has some dependence on opiates. So he is taking some medication at home. And we are not sure if the dose that we just administered is sufficient to reach that blunting of the sympathetic nervous system because of that dependence that he has and resistance. So again, in these patients with general anesthesia who are not able to tell you that the dose was not enough, the NOL index is relevant to help you appreciate that it was sufficient or that you should increase your dosage. The fourth case study, and this will be the last one, is one of these scenarios in which we could have kept administering some opiate medication, but based on the values that we have on the NOL index, we decide to change the strategy and administer antihypertensive drug. So this was a patient that was recruited in a research protocol. Hence, we had more data regarding the patient, and we know how the drug was standardized. So here we know that, of course, remifentanil 1 mic per kilo had been given prior to the intubation, along with a perfusion of 0.05. What we appreciate, I will bring your attention first actually on this kinetic of the NOL index right here with the events that exist here. So we have the incision of the patient that happens right here. We have after that the first trocar insertion, and after that we have the insufflation. And during all that moment, of course, the NOL index told us that the balance between nociception and anti-nociception was well controlled. At insufflation, of course, we know that there can be an activation of the sympathetic nervous system. And this is what we appreciate. We see that there is a kinetic in which we have a raise of the NOL index. We have the second incision, and based on that value, a first bolus of remifentanil 0.3 per kilo is administered. This is the standard dose that we usually give to make sure that we're able to perfectly tailor our boluses to the patient's need. We then appreciate there was a mild reduction, probably linked with the administration of the remifentanil or the decrease of the activity once the insufflation is completed. We have the second trocar insertion, which that this little increase, and we reach that specific moment in which we have a NOL index of 40. We have a blood pressure of 155 over 106. We have a depth of anesthesia of 0.8 Mac with a BIS level of 53. And at that moment, I recall that a bolus of remifentanil had been administered 2 minutes later. We appreciate that there is this downward movement of the NOL index. We also appreciate that we reach that flat line. We reach that moment where the NOL index is actually very low, probably in the sense that there is a anti-nociception. We are in favor of the anti-nociception. But at that moment, we also had a remaining hypertension. So this could have been indicating that the patient was experiencing pain because we just had the trocar insertion, we just had the insufflation, we still had that blood pressure that didn't move with our administration of remifentanil. And without the NOL index to help us guide our administration, it would have been natural to give a second bolus, maybe a third bolus to try to bring down this blood pressure. But because of the fact that on the NOL index, we were appreciating that we were on the side of anti-nociception with a NOL index of 1 and this flat line almost around 0, a dose of diltiazem instead was administered because we consider the patient has had this essential hypertension, and this is what needed to be treated instead of giving some further opioids. So this was my last example. I think what I want to emphasize in this presentation is this citation that appeared in the BGA in 2021. And in 2 words, benefits may be more likely obtained when monitors do not aim to replace, but to assist the clinician's experience. So the NOL index, in my opinion, is a very relevant tool to help me guide my decision-making. You have to consider the monitor and the whole spectrum of the data that you have from the patient. You have to guide your own decision making based on all these information, and NOL index provides some further data on sympathetic nervous system activation, and this is what I like about it. So thank you very much. I hope I was pretty clear in my explanation, and I am ready for questions.
Great, Pascal. Excellent job. My head is spinning from those case reviews. It's one of those you kind of had to be there. But what you did leave the impression with me that you believe the outcomes, your outcomes, be them faster emergence, less pain, less opioid, or any combination of those, not all of them apply for everything, are real.
Mm-hmm.
Which would you say are the biggest value adds when you use the NOL monitor in terms of improved outcome, and in which population? Pick the surgery and the patient type that it's the greatest benefit.
So two example comes to my mind very quickly, and I'll even give a third one because it's a research question that I would love to explore at one point, but haven't found the right way to do it for the moment. So the 2 first one are actually the patients that were explored in the previous webinars. And I completely agree that they are very, very relevant cases for the NOL index. So the first case are these patients in which you want to perfectly tailor your opioid administration. So we're thinking about the patient who have sleep apnea, who potentially have a sensitivity to opioid administration, and who most probably in most cases you want them to go back home after surgery because they were operated in an ambulatory setting. So you want to perfectly tailor your administration of opiate to this patient, because if you record apnea in the post-anesthesia care unit, you will have to lengthen your monitoring. You might have to hospitalize the patient depending on his compliance to CPAP. So this is the first use case that I really want to use an NOL index to tailor my administration. And on the other end,
let me just interrupt. So obese patients with these issues, we had a question, is there a study using NOL and opioid-free anesthesia? I refer that questioner to the Isabel Marcolino, who's very much a proponent of OFA. It's a very controversial topic, but we agree that in that population, if you were a proponent of OFA, opioid-free anesthesia, you would definitely want an NOL monitor to be able to minimize or optimize your analgesics, correct?
Exactly. I'm aligned with this. I think that OFA, it is a conflictual subject. There has been a lot of literature on this subject. I'm personally a fan of minimizing and not specifically avoiding, because a lot of the surgeries that we do here are major surgeries, and OFA is less feasible in my opinion. But using the NOL index, I'm able to minimize the administration.
Okay. Let me ask you real quick, summarize what those other 2 types are, because then I'm going to try and spin them into these questions we're getting. What are the other 2 types of patients?
Perfect. So the other patient is a combination of regional anesthesia with general anesthesia. So for example, I had a patient in which I conducted a brachial plexus block for a surgery that was very long and for which there were some part of the surgery that were on other parts of the body. So a general anesthesia was mandated and the regional anesthesia was highly beneficial for the postoperative setting. But of course, it's hard to assess what is the true performance of your regional anesthesia when the patient is immediately put under general anesthesia afterwards. And even if we are very, very, very good with regional anesthesia, this is not my specialty, but there are people who are very, very, very good with regional anesthesia. There are some cases where some nerves are spared, and you have to, if the patient was awake, he would talk to you about this discomfort. So when you have the NOL index, you can't blindly expect your regional anesthesia to work, and you're able to perfectly tailor when the surgeon is working on a part of the body that was less frozen by the regional anesthesia. So it's a second use case that I really like. A similar case would be with epidural, when there's an extension that goes beyond the level of epidural that you reach with your boluses when he was under general anesthesia.
Let me ask you a quick question. We have a question as, can higher anti-nociceptive agents help avoid unwanted patient movements? Spine surgery comes to mind. We don't like to use muscle relaxants. We do neuromonitoring. And how does that, can it help with that? Do you use it do you know people use the NOL in spine surgery as an adjunct to prevent movement?
So I personally don't use it specifically to avoid the movements. What I think is very relevant in context of spine surgery is mostly that these patients often had chronic pain, and it relates to that third case study that I presented. If they were already opioid dependent, you don't know what will be the response to the standard dose that you would have given to someone else. So you're able to increment your dose of opioid without overshooting because of that dependence. So this is more the use case that I do when we are having some spine surgery, not specifically for the pain, the movement reduction. Although I think it could work perfectly because it's monitoring something similar. And one of the old ways to monitor pain or nociception was exactly that movement, sometimes even with that cuff inflated to make sure that the rocuronium or your paralyzing drug didn't affect.
So real quick, Philippe says, can the NOL index help predict the occurrence of patient movement? This is for everybody in the audience. The NOL index is not a crystal ball, folks. It doesn't look forward. It's backwards looking. So it can never predict what the surgeon may do. There is a study in urological patients where they had more movement with the NOL monitor because they turned the REMI infusion to 0. You don't turn off your REMI infusion because you'll have no analgesia on board, and then a sudden stimulation may get that. So remember, it's not predictive. It looks back and it can help you, but and never turn off your REMI fentanyl infusions, just as an aside. What was the third case? We have a couple minutes left, Pascal. What was your third setting?
So the third case is honestly a general setting in which my personal feeling is that when I start using a triad good monitoring, I feel that the patient wake up and they are sharp way quicker. They respond to short orders. They can reply to your questions. Sometimes they even talk about your reduction in some dreams. So I've been turning my head around the best way to capture this kind of signal. So the true benefit of having that patient being sharper when he wakes up, I feel that the metric used in the literature, which is reply to a simple order or respond to pain questions, I feel that they are not able to capture this specific sentence that the PACU nurse will tell you, which is, wow, your patient looks sharp as he wakes up. So this is the third use case that I really like, and this is why I tend to use NOL index, depth of anesthesia monitoring in most of my patients.
Great. Well, wow. I'm going to do the last question real quick. Someone asking about in awake patients. There is a vast trove of data on NOL in ICU patients who are sedated and possibly paralyzed. Remember what Dr. Lafferriere said earlier, during anesthesia, we rely on the limbic system as the measure, and that's why it works. But as we awaken, the frontal and somatosensory cortices awaken, and they will have input to the sympathetic nervous system as well. So yes, NOL does not work in awake patients. You have to be very careful when you're emerging that you don't interpret the NOL as being purely nociceptive when you could have higher cortical input. Would you agree, Pascal? And
100%.
when do you stop looking at the NOL when you're emerging? When do you say, okay, now we're mixing and matching, the patient's awakening, I don't want to look at the NOL anymore? How do you do that? How do you make that choice?
Honestly, I mean, usually as soon as we end the surgery, the sutures are being made, the dressing is being installed. This is the moment that I usually stop looking at it, because I started lightening my anesthesia. The patient will start moving. There will be some movement artifact that starts to appear too. So this is the moment usually that I stop looking at it, and we start extracting the data from the NOL to conduct our research instead.
Awesome. Well, we've come to the end, folks. Thanks for attending. I hope you found this informative. I as well will go back over this and look at some of Pascal's cases. Maybe, Pascal, we can put those in a video and animate them so you can get the temporal relationship of those cases, because they were fascinating. Your experiences, you speak so freely about it, which means that it's so easy for you. But for us who are catching up, it's we're going to spend a little more time on it. Thank you to the attendants. I think we hit a lot of the some of the questions. There's a million questions, but folks, this should pique your interest, this technology. And you can be a healthy skeptic, as many people are, but you will be convinced that this provides real value, certainly in specific niches of the population: opioid dependent, bariatric surgery patients, other types of patients. So Pascal, thank you very much, and thanks to our audience, and we will close with a happy holidays to everybody.
Happy holidays. Thank you very much.